Hi friends, welcome back to allornonelaw. This is a medical video lecture, pediatrics, and today I'm going to talk about rheumatic fever. Okay, so rheumatic fever, you know very well, is a really very important disease. Okay, so rheumatic fever is nothing but it's an what you call it's an immunological sequel, immunological sequel, sequela of a previous group A streptococcal infection of the pharynx. This is very important. Remember, it's an infection of the pharynx, not the skin, because we get same infection by the same organism. That's a group A streptococcal infection of the skin, but this will not lead to rheumatic fever in future. But we should worry if the patient has group A streptococcal infection of the pharynx. Okay, so once the patient has a rheumatic fever, in future he can, this rheumatic fever is such a dangerous disease that it affects the brain, heart, joints and the skin. Brain, heart, joints and skin. So let's talk about the epidemiology of this. This disease is not common in United States. Okay, and what's the age, peak age? Peak age of this rheumatic fever is 6 to 15 years. Okay, and the incidence in the developed countries is around 0.3 to 3%. Okay, right, and the recurrence rate decreases to less than 10% over the 10 years. So as the child grows, the risk of developing this rheumatic fever in future is low. Okay, but the peak age group ranges from 6 to 15 years. Okay, and remember the another point that if the family has a history of what you call rheumatic fever, family with rheumatic fever, then there is increased risk in the child. Okay, all right. So let's talk about the what you call the criteria of the diagnosis or the symptoms. You know very well the criteria used to diagnose this is Jones criteria. There is another criteria that is Jones modified criteria. Okay, in a Jones criteria, we take two major or one major plus two minor. Okay, in addition to the major and the minor manifestations of this disease, the patient may appear pale and complains of abdominal pain, and even he can have epistaxis. Okay, and the most important thing, diagnostic for this disease is, can you guess what's the diagnostic for this disease? Is Aschoff's Schaff bodies. These are found in the myocardium. Okay, they are diagnostic. Remember, okay, they are diagnostic. Schaff's bodies. Okay, right. Let's talk about the Jones criteria. In the Jones criteria, we have major and the minor, right? In a major, we have joints in the form of polyarthritis, known as migratory arthritis. Polyarthritis. I'm going to discuss about this later. What's a polyarthritis? Let me list out the major criteria. And it affects the heart, known as a carditis, and nodules, that is subcutaneous nodules. Subcutaneous nodules. Then erythema marginatum, and the most important chorea, that is Sydenham's chorea. Okay guys, so these five are really very important and you should know very well about this. First, it involves the joint. Most important, the major criteria for a rheumatic fever according to Jones is joints, that's a polyarthritis. Then involves the heart, known as carditis, and subcutaneous nodules, erythema marginatum, and Sydenham's chorea. Let's talk about the minor criteria for this. For a minor criteria, we have arthralgia. Arthralgia is nothing but swelling of the joints. Okay, painful swelling of the joints. Okay, if there is any infection in that, inflammation, then we call it as arthritis. If the patient has a fever, raised ESR, or C-reactive protein, they are signs of inflammation, right? And the important EKG finding, that's a prolonged PR interval. Prolonged PR interval. And if the lab diagnosis of ASO titer, very important, ASO titers. Okay, right? So let's talk about this minor criteria: arthralgia, fever, raised ESR, raised CRP, reactive protein, PR interval is prolonged on EKG, and you see ASO titers. Okay, so let's talk about this, the carditis. Let me talk about the most common, that is arthritis. The most common manifestation of a rheumatic fever affecting 70% of the patient is arthritis. Okay, usually it affects large joints, but can affect, remember, this disease can affect spine and the cranial joints, because this can be asked in examination. It can affect the spine and cranial joints. Okay, what's the characteristic of this arthritis in these patients? It's a migratory in nature, means it affects the one joint in one time, and in the second time it affects another joint. But remember, in this migratory arthritis, it also means that patient can have two joints at a time. For example, this week he had a pain in the wrist joint, then the next week or after a few days he started to have pain in his ankle or a knee. So it keeps on migrating. Okay, so this is the characteristics of rheumatic fever. Okay, so what happens when you examine the joints are what you call as a red, warm, because of inflammation, swollen, and a very tender if moved. That's why there will be lack of mobility at that joint. Okay, remember, this arthritis of rheumatic fever responds very well to what you call aspirin therapy. Right, so these are important. The most common manifestation of the rheumatic fever is arthritis, remember. Okay, Let's talk about the next most common, that's carditis. So it affects what you call 50% of patients. Okay, if the carditis is involved, the patient will have tachycardia. Okay, and the murmur, the patient will have a murmur, and that murmur is due to, the most commonly it is due to, it's due to the mitral valve regurgitation. Okay, mitral valve regurgitation, and sometimes it can affect aortic valve regurgitation. Okay, and even sometimes can affect the tricuspid valve regurgitation. So it's a very less tricuspid. The most common is the mitral valve, remember. And the patients sometimes have a friction rub. When you hear his chest, you will hear a friction rub, and the friction rub is seen in pericarditis. So these patients can have pericarditis. On chest x-ray, you will find the cardiomegaly. Cardiomegaly. So ultimately, the patients, if not treated very well, then he can land up into the what you call CHF. Okay, congestive heart failure, right? So these are the things what we are looking, what we see in the patients with rheumatic fever. So let's move on to the another important major criteria, that is a chorea. So chorea is not so much common, but it's up to 15% of the patients can have this chorea. Okay, and remember the characteristics of this is it's a really very common in the prepubertal girls. Prepubertal girls. And the movement lasts on average for what you call, once it starts, it can last up to 7 months. And it starts slowly diminishing, and it can take up to what you call 1.5 month, 1.5 year to slow down. Okay, so how the patient will have this is nothing but is spontaneous purposeless movements. They will have a spontaneous purposeless movements. Okay, it's like a, say, what you call dance, all right? Spontaneous purposeless movements. And because of this, the patient will have loss of motor coordination, and in future patient will develop motor weakness. Okay, and another thing is that the behavioral characteristics of the attention deficit or ADHD and obsessive compulsive disorder has been seen with this disorder, this movement disorder. Okay, so the patient can have what you call ADHD, that's known as the initial emotional liability. Okay, so let's move on to the another one thing, that's a arrhythmia marginatum. So it's a really very less, that's a less than 10% of the patients will have this erythema marginatum. What's erythema marginatum is nothing but a pink erythematous macular rash. It's a pink erythematous, okay, macular rash. Pink erythematous macular rash. Often has a clear center and serpentinous outline. Clear center. Okay, and remember the characteristic of this erythema marginatum is it's non-pruritic, no itching. Okay, Another one characteristics of this erythema marginatum is it disappears when there is a cold weather and reappears when there is a warm. So it disappears when cold and appears when it's warm, right? So what are the locations where do you find erythema marginatum you should look for in a patient with a rheumatic fever? Is primarily on the trunk and the proximal extremities. Okay, so these are the locations you should look for: trunk and the proximal extremities. So let's talk briefly about the subcutaneous nodules. Subcutaneous nodules. Okay, then incidence is around the incidence of this disease is what you call incidence is around 2 to 10%. 2 to 10% of the patients. Okay, and if you examine, they are hard, painless, small. They are hard, they are painless. Remember the painless because this can be asked in examination. They are painless. The small size ranges from up to 1 centimeter. Swelling over what you call a bony prominences. Over the bony prominences. Just Google the images. Primarily on the extensor tendons of the hand. Okay, primarily on the extensor tendons. So the what are the what do you call it is not transient, it lasts for weeks or months. Okay, and remember this can also be found on the scalp and along the spine also. Can be found on the scalp and what you call along the spine, right? So remember the one point I would like to tell you that if the absence of tachycardia or murmur usually excludes the diagnosis of what you call a myocarditis in the patients with a rheumatic fever. So when you see there is a no what you call absence of tachycardia, no tachycardia is doing well, no murmur. Okay, so usually so mean it's such an important criteria for the diagnosis. So you should be looking for this in the patient with the rheumatic fever. Okay, and the rheumatic fever can cause long-term what you call valvular diseases, but stenosis and insufficiency, both the what you call stenosis and the insufficiency. Okay, so these are really very important points. So let's move on to the what you call diagnosis. Diagnosis. The diagnosis, you know very well the ASO titer. Okay, it's a ASO that is an anti-streptolysin O titer is the most commonly used. Okay, and it is elevated in 80% of the patients. 80% of the patients with acute rheumatic fever, and 20% of the normal individuals. So you can, if a normal individual, ASO titer can be elevated in 20% of the normal individuals. Remember, okay. And remember, the streptococcal antibody tests are most reliable evidence of preceding Group A streptococcal infection that leads to acute rheumatic fever. So it's the best. So other antibody tests exist, like we have what you call anti hyaluronidase, anti streptokinase, then we have anti deoxyribonuclease B, wherein at least one will be positive 95% of patients with acute rheumatic fever. Okay, and the positive throat cultures and a rapid strep tests are less reliable because they do not differentiate whether it's a chronic or whether it's acute. So remember that it doesn't help you to differentiate whether the patient is having an acute or a chronic infection, okay, by these tests, that is positive what you call throat cultures and a rapid strep test. Okay. Remember, if the patient's arthritis does not improve within 48 hours of what you call therapeutic aspirin therapy, may he may not be or she may not be having rheumatic fever. That's very important point. Okay. So let's move on to the treatment. What's the management? The treatment over here is upon the diagnosis. Once you diagnose the disease based on ASO titers and major criteria and other antibody tests, so you have to start with the treatment, that is with the benzathine, penicillin. Okay, benzathine penicillin, that is G. Okay, 1.2 million units IM, 1.2 million units IM to eradicate streptococci. Okay, and if the patient weight is less than 27 kg, you can give 600,000 units. Okay, so patient allergic to, what happens if the patient is allergic to penicillin? If he's allergic to penicillin, so what you have to give is 4 days of 4 days of erythromycin. Okay, 4 days of erythromycin, that's given around I think 40 milligram per kg per day. Okay, the 4 days of erythromycin. Okay, and once, if you want to prevent, the prophylaxis should be initiated in these patients. Prophylaxis should be initiated, that is a benzathine penicillin G, 1.2 million units, 1.2 million units IM, sorry, units IM every 3 weeks, or penicillin 200,000 units per orally, 200,000 units per orally, 3 times per day. Okay, or other option you have is sulfadiazine is given 1 gram per orally, once per day. Okay, so we have prophylaxis, we have benzathine penicillin G, 1.2 million units IM 3 weeks, every 3 weeks, or every 3 weeks in a, or the other thing you have is penicillin 200,000 units per orally, 3 times a day. And another option you have is sulfadiazine, 1 gram per orally, once per day. Okay, well, the length of what you call prophylaxis is not sure about this. Some says up to 18 years, some says up to 2 years, 5 years, some, it's all what you call, we cannot come to a conclusion. Okay, but remember, 75% of the patients recover within 6 weeks and less than 5% are symptomatic beyond 6 months. Okay, so this is really very important. And another important point I forgot to tell you in erythema marginatum is never found on face. Remember, like scabies is never found on the face because we repeatedly wash the face. That's the reason the scabies we don't see on the face, right? Whereas erythema marginatum is, that is not the reason, but erythema marginatum is never seen on a face. Remember. Okay, so thank you so much for watching this video. I'm sure this video was really very helpful for you guys for your examination preparation. Thank you so much. Take care.